Thank you very much. Good morning, everybody, and delighted to be here in the east of England, and the fact that the weather allowed the train tracks to work between London and Stansted this morning. I'm going to give you a bit of a pick and mix, really, of workforce issues. Up front, I need to be very clear, I'm not a HR specialist and I'm not a workforce planner, and therefore some of the things I'm going to present are very much from probably a hospital management operational bias and very much from what I'd expect clinical directors, medical directors and other senior clinicians to want to be involved in when we come to talk about workforce and 7-day services. First of all, Health Education England, we're a £5 billion organisation. We are responsible for the development of the future workforce of the NHS. We're not responsible for the day-to-day CPD that individual employers are responsible for. 2.4 billion of that budget is for doctors and dentists. My team take responsibility for the planning and the coordination of the junior doctors and dentists across the UK, not just England. We manage it on behalf of the devolved nations as well, and clearly work very closely in England with the Let Bs in terms of that coordination. Up front, I think you all know in East of England you have a challenge in terms of being probably not as popular as London as a place for junior doctors to go to, and that is something I think you need to think about. It's something you need to do in terms of loving your foundation trainees, making sure that they get the best possible placements and development during their 2 years with you. Medical mobility is decreasing hugely in the last 10 years. Doctors, once in training, want to stay in a geography, and all the feedback we're getting is they will choose geography over specialty, and therefore, if they want to be in a particular geography, they will more likely take their third or fourth specialty choice than actually move out of that geography. And again, if you look at the statistics, once you've got people through university, medical school and into the foundation program, if you can keep them through that foundation program into specialty training, you are more likely to keep them in your geography. And I would say that is something that you in East of England is something you may want to reflect on and work with Simon Gregory as your postgraduate dean and director of education and quality. This first slide is our new planning process, and I have to say it's only 18 months old. We're learning how to get it better and to make it more user-friendly so that we really do get a rich information from our Let Bs about the workforce requirements for the future for any given geography. It works in 3 iterations, so that we start in June and then do 3 iterations through the Let Bs where we share the information up into a national picture and then pass it back to say, we're not quite sure you've got it right. Are you really sure your providers are asking the right questions? Are you really sure X is enough? And some examples here. Last year, our providers all told us they wanted X number of nurses. Following Francis, we didn't think that was a right number. We added 750, but we still now today find ourselves short of about 2,000 nursing commissions. Nobody has raised with us the fact that they are short of sonographers, but at the moment most trusts have got at least 1 if not 2 vacancies of sonography, and the importance of sonography over a 7-day service is really important, but this information is not getting to us. So one thing I would plead the Senate to take away from today is how do you work with your local organisations to get the right information about your shortages up through your Let B, so your Let B can then commission on your behalf the workforce that you require. Hugely important and is not sophisticated in the way that we've got it arranged. That's a two-way process. You've got to engage with us as much as we engage with you. And if you don't think we've got that right, that is for local determination for you to tell us how we get it right for the East of England. We're currently in our final phase, and from today, if there are final tweaks that you think desperately need changing, you urgently need to talk to your Let B to get that changed in next year's Workforce Commission. What I would suggest, and particularly those who are coming to our workshops today, is to think through what you need to do to get that that thinking more sophisticated in your organisations, so that for next year's commissions we really are starting to buy the types of education that you require in the east of England for the workforce that you require. This is an interesting extract of where we're going with the current workforce across England. So I haven't got the east of England split of this, but on the whole the trends are pretty much the same. First up, you'll see the consultant workforce continues to grow. I don't think we make an apology for that, on the basis that in terms of ratios per 100,000 population, the UK is still well behind the rest of Europe, the States and Australia. And in terms of GP per head of population, we're slightly going down and in the wrong direction. So in terms of medical investment, it's still going to continue to go up in the way it has done in terms of the growth. Though we are looking to change some of the specialties, we recognise there probably at the present time in the system is probably some overgrowth in trauma and orthopaedics, diabetes, obstetrics, gynecology and a couple of others, and a recognised shortfall in, no surprises, general practice, psychiatry, emergency medicine and geriatrics. But even that, there are some surprising groups that we're just not getting to. So things like pharmacology, medical rehabilitation are just not hitting us in terms of people saying we need this. But we recognise across the country there is a national shortage of people that support medical rehabilitation. The next group to note is pharmacy, still going up, huge workforce. It's produced by universities. It's obviously hefty funded in terms of the output in the first instance. There's no government change to reduce that, and therefore there's likely to be a surplus of pharmacists in the system in the next few years. I think in HEE we would argue that your clinical pharmacists, if used, could be a huge supporter of not only doing work that other parts of the clinical team are doing and therefore they could supplement that, but also in terms of over 7 days working across the clinical environment in GP practice, in emergency departments and in the clinical environment to support clinical workload. Scientists is slightly going down. We think that's partly because of all the pathology reorganisations, the numbers people have left, and we haven't increased the commissions. I think that might be a steady state back upwards in the next few years. AHPs has slightly dropped, which is a concern considering the value of an AHP over 7 days, particularly for supporting effective discharge and rehabilitation. The other number that's slightly increasing is some of the, I've lost that one. Some of you can probably read it better than myself. Registered nurses is the other one that's gone slightly up, and again that's because of Francis. People are employing more nurses and asking us to commission more nurses. Another plea I would say is over 7 days, a lot of people are just assuming let's put doctors and nurses in. We genuinely believe that's not the right answer. We believe it's around skill set. And again, with CQC visits, if in doubt, let's throw doctors and nurses at it. There aren't enough in the system to supply you. And actually, in terms of cost, it's probably not the most effective way of moving forward. And again, very happy to debate that. I'm not an expert and don't profess to be an expert on competency frameworks, so I'm sure there are other people in the audience that know more about it than I. But I think we would argue that the use of competency review and skill mix planning should be clinically led. This should not be HR led, and it allows you to really look at a clinical workload and say, what are the clinical competences we require around this clinical workload, and how are we going to manage it, and what is the workforce mix that we require to manage that clinical workload. Yorkshire and Humber Let Be have worked with all their 16 providers using something called the Calderdale competency framework, which is something that allows them all to map and use the same language around the competencies they require against any clinical service. This is now something that's up and running across Yorkshire and Humber and has been very much taken on board by all their organisations as a way of being able to use the same language about the type of workforce they require, and also about being able to challenge each other about the different types of workforce mix individual hospitals are taking on. It does provide helps a shared understanding of roles, skills and professional accountabilities, and it really is around making sure you've got the right skills at the right time in the right place over a 7-day period. And it's a good way of getting into a conversation about how you manage 7-day services. I'll now talk a bit about the alternative workforce, because I've already indicated that there aren't enough doctors and nurses to go around, and actually I'm not sure that is the right solution. So we are looking through national programmes at a whole range of different professions that we believe are part of the solution for 7-day services, and trying to promote these through our LETBs in terms of seeking organisations who may want to take them on or have already got them and are looking to showcase them across their LETB geographies. The first one is around the advanced clinical practitioner. We are mapping the ACP in emergency medicine as an example, so that all advanced clinical practitioners that work in EDs for the future will have the same competencies as a junior doctor that's got their membership examination for the College of Emergency Medicine. The importance of this is there is a huge mix of nomenclature out there around EMP, AMP, ACP. By actually using a competency framework, you use the same language, and therefore one person with the right skill set, with the right title, irrespective of their working in whichever organisation, will be doing the same sorts of duties and can be expected to do the same sorts of duties. This not only helps in terms of us being then able to commission them at volume on your behalf, but it also, in terms of patient safety, means as people move around using these titles, somebody asking an ATP to go and look at a patient and do a particular task, you know that person is competent and confident, hopefully, to undertake that task. At the present time, we do not have that across the NHS. And when planning 7-day services, using this type of modelling is a really good way of getting into that conversation about what are we expecting these individuals to do, and what is their competence that they require. So these are the steps. It's around an assessment framework. We will be looking to commission more of these for the ED department, for the ED environment. That already is a 7-day working scenario, but there is no reason why advanced practice practitioners cannot work across other environments in the wards and in general practice. People may have heard of physician associates. The Daily Mail called them doctors on the cheap the other day. In the UK, we've only got 250. In the United States, they've got 85,000. We see this as a role that works alongside senior clinicians to do given tasks that these people are competent to do and manage. The turnover of PAs is very low. On average, they'll stay with you a decade based on current experience. They are trained in the medical model. They are scientists on the whole by background, although some people have come into the PA route through nursing and other professional groups. And they can do a whole range of work. So at the moment you can find PAs in general practice managing a whole heap of long-term conditions on behalf of the GP, but under the supervision of a GP. We've got PAs working in emergency departments, we've got PAs working in outpatient departments looking after a given set of long-term conditions patients. We in HEE do see this as a way forward. They are relatively easy to produce. They come from a science background. Up until last year, there was only one programme in the country, which was my own ex-trust, St George's in Tooting. We now have 5 programmes open, so there's already over 200 extra PAs in training as we speak, and 7 more universities are opening programmes next year. So I would urge you to look at this. We are about to put on our website a film which case studies PAs working across different clinical environments, how they work, how they train, and how you can set up a programme. I'm pretty sure there were some universities from the east of England and some of your academic institutions at a recent programme in Birmingham, which was how to set up a PA programme, but worth looking out for this. They are on a voluntary register at the moment, which we're funded through the Royal College of Physicians, which is a multi-faculty registration place. We are suggesting to all employers that if they employ a PA, they do not take somebody who is not on the voluntary register. We are talking with regulators about how we can get these people regulated, because one of the additional benefits, if we can get them into a regulated format, is that they will then be able to go through to advanced prescribing. And one of the big issues for the Americans using PAs is their PAs do prescribing, which is a big benefit and would certainly be a great benefit here in the UK. Pharmacists, I've already talked about the growth in pharmacists, a lot of them coming out, a lot of different roles that they can take on over a 7-day period. Some of you may have caught the press from the Royal Pharmaceutical Society on Sunday, which was showing how pharmacists are now saying how much they can manage minor ailments and other conditions that otherwise patients would have gone to their GP to see. HEE is setting up a clinical skills training program for existing pharmacists in retail to be able to give them the clinical skills training they require to take on this service. And we have a number of pilots of pharmacists working in different models in acute services, particularly in DED, both in the front part of the ED, managing minor ailments so the patients don't get through the front door in the first place, or actually in the ED offering clinical pharmacy advice to the juniors, supporting scripts writing and helping manage polypharmacy across the 7-day period. On the ward basing, having introduced this myself at St George's, the 7-day clinical pharmacy service at St George's made a huge difference in terms of supporting clinical prescribing, supporting the medics at weekends in particular and out of hours in clinical prescribing, and trying to manage the polypharmacy both of admissions and discharges. Paramedics. There's a national shortage of paramedics. People are cottoning on to the fact of the role of the paramedic. Though what would surprise you, possibly to know, is that we do not have a single entry point for educational entry for the paramedic profession. At the moment, they can come in from in-house training, they can come from foundation program, they can come from diploma entry, and some of them have got a degree. That leaves a very mixed economy out there across the country in terms of what our paramedics can do. And all 10 English ambulance services have different scope of practice to what their paramedics can do, which means over a 7-day service, in the way that the ambulance service runs, they're all doing different things across the country, which means in terms of ambulance-borne rates of patients into ED is very different. One of the things that we are looking to achieve as a UK programme is to introduce paramedics being at degree entry only. At that point, it means that we can agree a single scope of practice for what they can do, and once we've agreed that with a clear career structure that follows the AHP framework, it means that paramedics can then move through the non-medical prescribing board to do advanced prescribing. That could make a big difference for us over 7 days, not only in terms of supporting our patients wherever they may be out of hospital, but with a view to reducing the number of patients that are actually taken to a hospital by probably up to about 25% compared to the current rates, which is quite significant and will be a material difference to hospitals in terms of managing their acute workload. GP practice have cottoned on to the fact that this profession, which is a relatively new profession compared to others, actually can do a lot of work around urgent care, and certainly the national work on it through NHS England around emergency urgent care. There's going to be a very large reliance on the paramedic as a profession keeping patients out of hospital. Some GPs, particularly on the south coast, have started recruiting paramedics directly into their practices because they've recognised that these people can start managing their urgent care workload and be part of the GP practice. Equally, some of the ED departments around the country have recognised the skill set of the paramedic and are employing paramedics directly to support the ED workload, particularly when you consider the shortage of EM doctors at the present time. What I would ask, though, is don't all rush out to go and employ paramedics, because East of England is already short of them, and you'll just cause another problem down the line in your own system. But it's certainly something I would urge you to support in terms of your local ambulance service, in terms of the investment and the growth of this profession. And now for something totally different. As a chief operating officer in a large teaching hospital, I would have never thought of looking at the organisation of structure of the delivery of medical education as a way of me reorganising the hospital to, one, make it more safe, two, make sure that my trainees I had responsibility had good education, but actually saved me money and allowed me to reorganise the hospital over a 7-day basis. We've just completed a 2-year piece of work called Better Training, Better Care, which was based around a couple of reports on medical education, the main one being from Sir John Temple on time for training. John, who is a surgeon, was asked to look at why Working Time Directive was causing problems in the delivery of medical education, and actually was asked on behalf of the Prime Minister, could we continue to train in the 48 hours available to us? And John's findings from his report was yes, and we were asked to then, at the time, set up a programme called Better Training, Better Care to say, now go and pilot this to demonstrate it can happen on the ground. John's mantra was threefold. One, if you're a senior educator with a patient in front of you and you have medical trainees or indeed others around you, take that opportunity to do some education and training. Not only does it mean that you're actually making sure that the people you're responsible for in terms of education get educated, but actually you can make an assessment at that point of the competence that your trainee is working to at a given time, but also an assessment of the confidence your trainee is working to at a given time. The second point was around appropriate supervision, and that doesn't mean that we've got to have consultants or GPs working 24/7 in the organisation, but it does mean having a system arranged so that you as senior clinicians understand the confidence and competence of your trainees at any given time. And the third mantra from John was, if you're going to reorganise clinical services, take into account the education and training needs and do not disrupt the pathways for your future workforce. And you'll probably appreciate, and I know this has happened in East of England, the postgraduate dean will remove trainees if the quality of training does not meet the national standard required. We set up, asked for bids from around the country for people to want to pilot John's mantra. And I'll just take you through a couple of examples which make a big difference to 7-day working. The first is Mid Cheshire. They've just won the Health Service Journal Award for Patient Safety and Innovation on what is actually a very simple project, but made a huge difference to them in reorganising 7-day acute medicine across the Mid Cheshire Hospital, which is a small 400-bed DGH just outside Crewe, and its junior doctor ratio to consultants is the lowest across Mersey. So if they can do it in Mid Cheshire, I can assure you you can do it in East of England. What they recognised and what they wanted to recognise was Hando was a great place to do education and training and to get the Temple mantra around appropriate supervision. Because if you get feedback from your trainees on the patients they're responsible for, you understand how they're managing the patient work caseload and are feeding back to you on a 24/7 basis. So in effect, you're putting a 24/7 QA programme 7 days a week into the system. So what they did was they bought a relatively cheap proprietary software program that linked to their patient administration system, which meant that all the tasks that the juniors were writing down at handover were written down electronically onto the system and could be tracked 24/7 by anyone anywhere in the hospital, or indeed by consultants out of hours from their home base. The trainees, of course, were now not writing things on scraps of paper. It all went into the system. They, Kelsey suddenly got a lot more careful about what they wrote down because it wasn't on a scrap of paper. It was going into the system and somebody somewhere was looking at what they were doing. They also reorganised their handover room, which is shown here in the picture, to a bit Starship Enterprise, where they had a big TV screen, which the PAS linked into, and all the patients they were responsible for came up on the screen and identified the junior doctor that was managing them. And they used S-bar down the left-hand side of the room, and every patient went through using the S-bar technology in terms of the situational awareness, what was happening to them, the assessment and their review. The bed manager and the key nurse for the unit was on every handover, and they had a zero tolerance for non-attendance at handover, which was signed up to by all the consultants and all their juniors. That one was a bit more tricky, but once they got it through, and once peer pressure put on everybody that this is half an hour, 3 times a day, and it's electronic, let's do this, they worked with it. Mid Cheshire, from doing this, not only their consultant suddenly said, you know what, this is a really good way of tracking what our doctors are doing. We get a much better feel on a regular basis about what our trainees are doing, the competence they're working at, but the confidence by which they're presenting back their patients. The trainee said it, actually, we're now getting some senior support on a regular basis. This makes us less frightened to call the physician out of hours. We've got a better relationship with our educators. If we really need to call them, we feel we can do so. The electronic technology meant that at the end of this process, at the end of the project over a 12-month period, the amount of items that were being handed over to the next lot of people coming on had reduced by 83%, which means in terms of patient safety and delivery of patient service, they were getting the right tasks done, they were getting the right diagnostics done, they'd built the right relationships with the diagnostic teams on a 7-day basis to get the results working for them in this project. That made a big difference. They have saved nearly £500,000 in patient bed days. Their in-house cardiac arrests have reduced. And they found that when their trainees moved away from Mid Cheshire to other hospitals, I got a phone call from the GMC saying there's something fascinating going on in Mid Cheshire because suddenly all the trainees are writing into their GMC survey, why is the hospital I've just arrived in not doing handover like at Mid Cheshire? Great accolade in terms of something that on the whole, although a physician championed this was trainee-led and trainee-delivered. And I think there's a message there. We've got some very clever people that sometimes need to be allowed to be let go and to manage things on a multi-professional basis and allowed to plan a change that works for them in their education but also delivers very good clinical service. So for 7-day care, this project, it helped them look at their rota design and for out-of-hours care. And I have to say, from my own experience at St George's, if you haven't got your out-of-hours services rota working properly with true integration with the out-of-hours bed management and nursing system, then you're never going to achieve 7-day services. I have to say, I think it was the biggest thing that I fought with, but actually once we'd got it in place, made a huge difference to getting some of the other 7-day services on board. Mid Cheshire found that all their out-of-hours tasks on the whole were completed. That sped up patients through the system. And, as I say, statistically significant out-of-hours discharges at the weekend. Their discharges at weekends went up by 30%, and their length of stay came down from 6-point-something to 5.1 days. This has allowed pilots to encourage managers to look at what happens at that hospital at night. It supports the hospital at night team, and it very much places the patient at the centre of where they need to be. 3 final slides. I go back to this. For anyone born before Duran Duran were in the charts, it's too late for you probably, but for those that were born past that date, they're in a generation that believe in a cause, not an organisation. And I think those of us that were born in the baby boomer or X generation that are used to a more directional leadership, we are probably making a mistake. From all the projects and the pilots that have come out from this, which will be on our website very shortly, we have found that by letting loose these millennials on projects, they not only work in a very different way and think in a different way to the older generation, but once allowed to do something, their innovative skills and their QI is actually fantastic, and they don't need to be directed. They get on and do. And we've got many examples where they've just used social media to bring about a change. So one of the up things from the whole of this program and our pilot show is let the trainees get on and show their leadership skills, give them the right support, but actually you'll get a huge amount of investment back from them. And I've given you the Mid-Cheshire example here of one that worked well. Don't forget your education and training when thinking about 7 days, because if you move things around, you really can continue to do education and training on a 7-day basis. It keeps your organisations as a learning environment, and you're more likely to get a safer or a more innovative organisation, but a learning environment is more likely to be a patient-safe environment. We found, actually I'll just go back to the previous one, Leeds and York Psychiatry Unit allowed their trainees to reorganise their rotas. They decided then to amalgamate from 3 sites down to 1. This was all trainees decided to do it. They managed to move 40% more medical time onto days over a 7-day period by doing that. And that was signed off by the trust because it was such a major shift, just because they'd taken the rota design away from managers like me and given it to the people that were actually in the rotas and actually, when thinking out of the box, thought up of a different way of working. So integration of training with care really can make a difference, and align the two have very much synergistic effects rather than keeping them separately. And finally, you can use the fact that by looking at education and training and the way it's delivered does have an effect on the culture and the efficiency and effectiveness of the way your organisations work. And this is not just about doctors. All these projects were worked on a multi-professional basis. And I think the difference of that was you had trainees that suddenly started to learn with the other parts of the clinical team, and the other clinical team started to respect what was happening there, which again is not always the case in the way that we currently manage the hospitals. So for my final slide, this is not just about doctors. It takes time to produce the future workforce. Don't forget it takes 15 years to produce a consultant. Therefore, let's not just assume that it's going to be consultant-led. Competency frameworks really will help you. Work with your local workforce planners here in your Let B about what you require. Let us know what you need to be. Don't forget your current workforce, your own CPD, and keeping people in your current is clearly important. And I would just stress, I would have never thought as a COO to ever look at medical education, but by looking at it in the way I've described from better training, better care, it really can make a material difference not only to the quality of education, but the delivery of patient care over a 7-day basis. Thank you.